Our final presentation of the morning session is from Zachary Wagner. Zachary did his PhD work at Berkeley, and he's now here as a postdoctoral research fellow. He's going to talk about the role of price and convenience in underuse of oral rehydration salts to treat child diarrhea, a cluster randomized control trial in Uganda. Zachary.
Thanks. Is there a clicker? Oh, got it. Okay, thanks everybody. Somehow the diarrhea talks are always right before lunch. It always works out like that. Okay, so I like to motivate this work in two ways. So the first way is just that there's a lot of really effective health technology that's underused in poor countries. This leaves preventable and treatable illnesses as leading causes of death. Community health workers are thought of as this really promising strategy for increasing use of things that we think people should be using, things like bed nets and clean water. These programs are really broad. They're all over the world. However, there's a lot of variation in the way that they're structured. We don't really know how they should be structured in order to maximize coverage. So, for example, there's growing support for this entrepreneurial model of community health worker product distribution, where they sell health products back to their community, whereas most of the public sector programs provide products for free. We don't really know which strategy is better. Similarly, there's a lot of community health workers that deliver products to the door, whereas others require retrieval from a different location. Again, we don't know which strategy is better. So in this study, we experimentally test different strategies of community health worker distribution of treatment for child diarrhea, and these strategies vary in the extent to which they impose monetary costs to the household through charging, through prices, and then hassle costs to the household through requiring retrieval from a different location. So the second motivating factor is really the important one. This is that, diarrhea is still the second leading cause of death for kids, 500,000 children dying each year, and pretty much all of these deaths could be averted with the use of oral rehydration salts. ORS is a sugar and salt solution that's mixed with water, and it allows children to absorb fluids much more quickly than normal water. It's been around for a really long time, been around since the 1960s, and it was lauded as one of the most important medical advances of the 20th century by the medical journal The Lancet, so it's really a big deal. It prevents something like 93% of all deaths that result as a result of diarrhea. However, only about 46% of cases are treated with ORS in Uganda. That's a pretty similar trend throughout sub-Saharan Africa. It's slightly lower in some parts of South Asia. And it's really held steady for a long time. Zinc has been introduced more recently to be used in combination with ORS. Zinc has some extra morbidity and mortality benefits, and only about 40% of cases are treated with zinc. So ORS comes in these packets, and each one of those packets is mixed with a liter of water. Each packet costs about 7 cents, so it's incredibly cheap. Zinc, it's about 15 cents for a packet of 10 tablets. It's 1 tablet a day for 10 days. It's 2 packets of ORS per case of diarrhea. That's the recommended amount of treatment. So the health benefits of ORS are really well documented. We know that it's really good at preventing mortality from diarrhea. This is documented in the medical literature. However, there's very little evidence in the social sciences on what works to increase ORS use and why ORS is underused. A recent systematic review found that there was just not very many studies that even addressed this, only a few randomized controlled trials, and pretty much only focused on South Asia. So we really have no evidence from sub-Saharan Africa on what works to increase ORS use. So the main contribution of this study is that we're evaluating and comparing some novel interventions designed to increase ORS use, but we're going further than that also. We're also isolating for the role of 2 potentially important mechanisms that could be leading to underuse. And we're focusing on price of ORS and the convenience of accessing ORS. So we designed a cluster randomized controlled trial across 118 villages in Uganda. And this trial was designed to answer 3 primary research questions. So the first question is this impact evaluation question. We wanted to know if this intervention that we designed, if it works to increase ORS use. So we wanted to know if free distribution with preemptive home delivery of ORS by community health workers, if this increased ORS use relative to the status quo. And the status quo is still having community health workers, but they sell ORS and they don't deliver ORS. The second two research questions are more mechanism questions. We wanted to know if price was an important barrier to ORS use, and we wanted to know if convenience is an important barrier to ORS use. And we're able to get at these questions with our experimental design. So we worked with BRAC. BRAC is it's the largest NGO in the world. It's a Bangladeshi NGO, and they run a community health worker program in Uganda. Their community health workers sell a line of health products back to their community. They're in about 3,000 villages, and they get to keep the profit, so there's a profit incentive there to make the sales. They're in about 3,000 villages in Uganda. They're also in 12 other countries, so it's a really big program. It's very similar to another program that's based in the Bay Area called Living Goods. Maybe you're more familiar with that, but it's the exact same model. So we randomly assigned community health workers to one of 4 groups. The first group was just a control group where we did nothing. Here, community health workers charged for ORS, and they did not deliver ORS. This first treatment arm is a free and convenient group where we had community health workers deliver ORS to all the households for free at the beginning of the study. So all the households have ORS stored in their homes for when a child comes down with diarrhea. It's free and it's convenient. This third treatment group is a convenient-only group where we had community health workers, again, make the exact same household visits. However, instead of providing ORS for free, they offered to sell ORS at the door. So it's still convenient, it's just not free. And then this final group is a free-only group. Here, again, we had community health workers make the exact same household visits at the exact same time. However, instead of providing ORS for free at the door or offering to sell, they provided caretakers with a voucher that could be redeemed for free ORS at a different location. So it's still free, but it's not convenient because they have to leave the home to go get the free ORS. So comparing this free and convenient arm to the control arm, this is our impact evaluation question. What's the impact of this full intervention relative to the status quo? Then comparing the free and convenient arm to the convenient-only arm, this isolates for our price effect. Comparing the free and convenient arm to the free-only arm, this isolates for our convenience effect. So we did this in 118 villages, and we did a baseline survey, and then we did our interventions. Community health workers made the deliveries. We did a 1-month follow-up after that. So it's only a 1-month follow-up period, which is a pretty short period for a randomized controlled trial. But it's enough time for about 30% of the households to have had a case of diarrhea. So diarrhea prevalence is very high in Uganda. And this is important because we needed cases in order for the caretaker to make the decision about whether or not to use ORS. So this resulted in about 2,400 cases of diarrhea to analyze at N-line. Important thing to note is that adherence was not very good in terms of the community health workers carrying out the intervention. Only 61% of the households that were assigned to this free and convenient arm actually received a free home delivery. Only 20% of the households that were assigned to the convenient-only arm actually received a home sales offer. Only 42% that were assigned to the free-only arm actually received a voucher. So they didn't carry out the interventions as we wanted, but this is part of the effect, and we're analyzing everything intention to treat. Okay, so this is our main outcome here. So on the y-axis here, we have the share of cases that were treated with ORS, about 56% in the control group. A big increase as a result of this free and convenient intervention. We see a 21 percentage point increase, which is about a 37% increase. And remember, only 60% of the households actually received this intervention. When we compare the free and convenient arm to the convenient-only arm, this isolates for our price effect, and we see a 13 percentage point increase here. So price appears to be an important barrier to use. Convenience was not important. Only difference here between the free and convenient arm and the free-only arm is this delivery mechanism that didn't have any effect. We also see a big effect when we look at ORS and zinc combined, which is what the World Health Organization recommends. We see a larger effect there. We also see a big price effect here. Again, no convenience effect. We also look at time to ORS initiation. So this is the share of cases that were treated with ORS on the same day that the diarrhea episode began. So again, we see a huge effect as a result of this free and convenient arm, a doubling of the share of cases treated on the same day. And again, we see a price effect. This is the only outcome for which we see a significant effect of this delivery mechanism. So delivery seems to just shift the timing a little bit. We also see a reduction in antibiotic use. So that's important because most cases of child diarrhea are viral. Antibiotics are often overused. Okay, so why is this important? So we show that price is this important barrier to ORS use in Uganda. Having community health workers switch from charging to free distribution substantially increases ORS use. BRAC's community health workers are in about 3,000 villages in Uganda. If all of them switched to free distribution, this would save about 19 lives per month. And it's really cheap to do. It's, this is a very simple, very cheap intervention, easily scalable. We also show that price is this important barrier, so there's a lot of other interventions that could be done to increase access to free ORS. And these are a bunch of organizations that are working to increase ORS use in Uganda. There's organizations all throughout the world that are trying to do this. Increasing access to free ORS could be a good way of doing this. Finally, we find no convenience effect here. We find that convenience is not very important. Important to note that it was only about a 5-minute walk to actually redeem your voucher, so it wasn't very inconvenient. I'm getting the stop sign, so I'm going to stop now. But I don't believe this effect, so I'm happy to talk to you about why I don't believe it afterwards. Thanks.
Please come up to the microphone and introduce yourself.
Rosalind Payne, I'm in philanthropy. I don't think anything is free. So one of the issues here is who is actually, though, paying for those where perhaps the consumer is not paying, but somebody is paying for that distribution. And how does a government decide from a priority point of view as to where they're going to spend their money, or others who are funding those workers who are going around?
So that's right. In this context, BRAC would be paying for it. So right now, they heavily subsidize ORS that they distribute. They would just subsidize it a little bit more, essentially. Governments already give ORS away for free. So governments already think this is a good idea to not have people pay for it. But in this context, BRAC would be the one that's paying for it. And BRAC likes to have prices because they think it does a good job of screening out people that maybe not willing to use the product. People don't value things that they don't pay for. That's the reason why prices are often attached to these types of health products.
My only comment, though, on that is that if the government's giving it away free, still they are paying for it. And in resource-limited areas, you have to make those priority decisions as to how you're spending your money.
Right. So I just want to note that this is about $64 per disability-adjusted life year averted. So ORS is incredibly cheap and incredibly effective, so it tends to be a good investment.
Hi, I'm Amy Christosik from Pediatric Infectious Disease. Hi, I'm Amy Christosik from Pediatric Infectious Disease. Thank you for your nice presentation. My question is, why not just teach the mothers to make ORS at home with salt and sugar that's available to them? Although I guess it would be missing the zinc.
That's right. Yeah, so this is a question I get pretty much every time I present this work. So the World Health Organization has actually moved away from teaching people how to make ORS at home. The packets have they have this low osmolarity salt, which allows the body to absorb the fluids a little more quickly. I think there was worry about people not making it correctly and then it not doing what it should. But that was actually another intervention arm that we wanted to test, but we didn't have the funding to actually have another treatment arm.
Laura Kwong, I was wondering if you also had data on why CHP compliance was so low and what can be done about that, and how you would suggest changes if you had a scaled-up program with even free distribution.
Yeah, I think that's a great question. CHPs, CHWs do not adhere to their duties all throughout the world. That's pretty common. 60% of households receiving a visit is pretty high. So I think it's an ongoing debate about how to get community health workers to adhere to what we want them to do. Maybe it's through financial incentives. Maybe it's through better monitoring. It's not totally clear. So one of the seed grants that we got is focused on that, though, using mobile phones to try and improve adherence to stuff.
Hi, Nina. My question is actually similar to Laura's with respect to, you said there's a profit motive for the community health workers that are selling the products.
Yeah.
So was there any sort of differential adherence to the treatment according to whether or not they were in the free or convenience arms?
Yeah, I love that you asked that because I didn't have time to add a slide on that, but that's true. There was differential adherence. It went the other direction, though. So we would expect if you had this profit incentive, you would be more likely to go try and make these sales because you actually get to keep the profit from the sales. Providing it for free, you don't get any financial incentive, but you do get the community recognition. So if you're altruistic, if you have pro-social motivation, you might be more likely to make the deliveries if it's free, and that's actually what we see. About 60% made the deliveries if it was free. Only about 35% did if they were charging. So they didn't like the charging, which is what the model is based on. So it's kind of interesting.
Thank you, Zachary.
Thanks.